Hi and welcome to the new episode of Brain Attack series. Today we are going to be talking about the role of a speech language pathologist and what they do in the management of a stroke. So this can be So now we have listened to how a speech language pathologist plays a role in rehabilitating a patient's speech and language. Now another big portion that they play a role in is the swallowing. Now in swallowing, again based on, just like she said, based on the patient's status or the severity of the injury they have had, the patient is going to be in different segments. That is, they could be either in a coma where they are not responding, they are not conscious, and that time we take a different route, or they may be just getting aware, they may be still having their tubes, they may have major issues, and this is where we work the most. And then there is a later stage where they are mostly okay, but they may have some minor issues, very little drooling or something of that sort. So while the patient is not able to swallow, they get their nutrition mostly with tubes like the RT tube, Rice tube, or the PEG tube, which is percutaneous which is percutaneous endoscopic gastrotomy, and this is explained in detail in another video of ours. So and some of these patients may also be on a tracheostomy, which also affects their swallowing assessment and their function and the treatment, and this can also be seen in the same video as before. So after a stroke, whenever a patient has any kind of swallowing issue, it may be in the mouth, it may be in the way they swallow, it may be in their throat, it may be in the esophagus, which is your food pipe, it is called as dysphagia. So the entire process of swallowing is divided into four main phases. The first is the oral phase. So this oral phase itself is of two types. First is the oral preparatory phase that we call. In the oral preparatory phase, as the name says, you take the food into the mouth, or if it's water, and if it's food, there is chewing, and then the big pieces are broken down, it's made into a bolus, and that is called as the oral preparatory phase. So if a person is having an issue in the oral preparatory phase, they may have some drooling that happens. The food, you can see some food, if it's very mild, it may be just here, otherwise it may come onto the dress, and that is very difficult in a social situation as well. They may be having difficulty in biting, they may have difficulty in chewing, they may have food left in the mouth, they may have some pocketing of food on this side or this side, and these are the kind of problems that you would see in a person who has a difficulty with the oral preparatory phase. Now why does this happen? So they may be having some weak muscles. You can see that one side of the face is little weak, it may not move, it may be drooped, and they may not have function. So there are two things. One is the strength, that is, if may be weak. The second thing is that the range of motion, that is how much it can move. So sometimes the strength may be coming back, but the movement, how much it moves, can be difficult. For example, you have something stuck on your teeth. If your tongue cannot move till that place, it's very irritating. So that is how important the oral preparatory phase is as well. So here what we do, because the cause is the weakness and a strength problem, we try to facilitate that. We increase the muscle tone, we improve the strength of the muscle. There are different resistance exercises that we do to make sure that the movement is there. They increase the movement or the range of motion, and this way it helps to control and improve the oral preparatory phase. We also do other things to improve the lip seal, improve the lip strength, because lips also play a very important part, just like the tongue, and this way the overall oral preparatory phase is improved. So after this comes the oral transfer phase. So once you have prepared your food or you have kept the water in the mouth, you have to now make sure that the food gets transferred from the mouth to the pharynx. This pharynx is basically your throat, that's almost from here, till your food pipe starts. So the space between your oral cavity and your food pipe is basically called as the pharynx. So now when the person has to move this food from the mouth to the pharynx, that transfer is called as the oral transfer phase, because there's a lot of oral component that happens. Your lips have to be sealed, your tongue, if you imagine how you would swallow a food, the tongue, it closes up from the anterior part, pushes the food to the back. So there's a movement like this that pushes the food to the back, and that control has to be there, so that as you're pushing, the food shouldn't go into the throat, because that can cause a problem in the pharynx. The food may get into the lungs and you may choke. Sometimes when you're absent-minded, you're talking and eating, you choke or you cough. That is because you're not controlling the food. So because of that, the food may get what we call as a free spill, or a early spillage happens, and the person may experience some difficulties with regard to that. So the oral transfer phase is just as important as the oral preparatory and the pharyngeal phase, because here we have to make sure the control over the food and the transfer happens properly. If the transfer doesn't happen properly, what else can happen? There can be residual food in the mouth. So after you swallow, there can be some food remaining in the mouth, there can be water remaining in the mouth. We call it as pocketing. So on both sides of the cheek there may be some food remaining, and all these problems can happen in the oral transfer phase. So again, the problem here may be a base of tongue strength issue, or sometimes even just your attention can be a problem here. So we make them aware, we teach them the proper strategies, the steps of swallowing, and also we do some tongue based strengthening which can help all this to improve. Another thing that can happen in both of these situations, in the oral phase as we say, which is the preparatory and the transfer together, are sensory issues. If there is some sensations that is less in the mouth, that can also cause an issue like this. If the swallow reflex is not working properly, that can also cause an oral phase issue. So here what we do is improve the sensations in the mouth. So we do something called as thermal stimulation. So by the name, you know, it is something to do with the temperature. So we give some hot stimulation, cold stimulation. We alternate between those to improve the sensations. Then we do something called as a gustatory stimulation, that is basically giving them different tastes, but it will be extreme tastes. We will give them a sour taste like with lemon to induce the swallow reflex, or we give them honey which is like very sweet. That also helps with improving the sensations in the mouth. So now after the food is transferred, it reaches to the pharynx, which is this portion. So here what happens is, what should happen is that the food should go from there directly into the food pipe and then to the stomach. So that is through the esophagus it should reach the stomach. Now people who have problem with pharyngeal phase, what can happen is sometimes the food can go into the lungs, that is into the windpipe, and that can cause a problem like a pneumonia, or the food may be stuck there, the elevation. So you can keep your hand here and swallow and say, you can see a small thing that moves up and comes down. That can get affected, the elevation or the moving up of that can get affected. So all of you would have definitely heard of the epiglottis, which sort of protects your windpipe during your swallowing. So the epiglottis can get affected, due to which if it remains open, the food can get into the windpipe. All of these things together is what we call as pharyngeal phase, or what problems can happen in the pharyngeal phase. So now if there is a problem in the pharyngeal phase, what are the symptoms you would see? So your trachea or the windpipe, one of the protective mechanisms it has is a cough. So that's the reason when you also would choke on food, you cough and you get it out. So that is one thing that you would see. You would see there would be coughing in the patient. You would see some kind of tearing up of eyes, some facial expression changes, or as when we give, or in a hospital setup, if you would see, we would always have a pulse oximeter connected to the patient, and we would see the oxygen levels in the patient. If there is some food entering into the lungs, we would see that the oxygen levels are coming down. So another thing that you can see in these patients is wet voice, what we call it, that is when they speak. So we give them food. So before we give them, we make them say something, or just ask them to say ah, and we give them the food, and then we tell them to say it again, and then we see if there is a change in the quality of voice. So we call it as gurgly voice or wet voice. That means when they say ah, you would know that there is something stuck in the throat, that is there is something in the vocal fold, and this is another indication of somebody having a pharyngeal phase issue. Now for a person who has a pharyngeal phase issue, what do we do? So we strengthen their pharyngeal muscles. There are a lot of compensatory strategies as well as restorative strategies. So compensatory strategies are those. So you would know that, okay, for example, something like a chin tuck. So patient would bend down like this and swallow, and this sometimes improves the safety of swallow. So for somebody who has a very mild issue or who is improving and now doesn't have much of an issue, we would suggest this method. We would suggest the compensatory method so that they can swallow it safely, something they can eat, because the joy of eating food is everything. So we would allow them to eat it till the patient regains their normal function. So while the patient uses compensatory strategies to eat the food, we would parallelly work with restorative strategies to improve their swallow, and slowly the patient will be able to come out of all the tubes they have and their swallowing will get improved. Now now the last phase that we have is the esophageal phase. So here what can happen is there can be movement issues, there can be peristalsis that you would know, where there is contraction that happens that helps to move the food down to the stomach. There can be a puncture in the esophagus and all these things, but these are usually not dealt much in detail with us, and in neurological patients or patients with stroke, this is not seen much until and unless there is some other cause, that is until and unless there is something else causing this problem. Now what else can happen is that there is no direct problem to any of these phases, but the patient's cognition or their understanding is not that good. So I have had a patient who, if I would give a biscuit, she knows how to chew, but she doesn't know that she has to bite it and chew. So if I give her the biscuit, she would sort of lick it like how she would have an ice cream or a popsicle, rather than biting the biscuit and chewing it. So if I make it into a paste, into a semi-solid form and then give it to her, then she knows, okay, she has to chew and she has to swallow. But I would give the biscuit in her hand, she did not know she has to take it to the mouth, bite and chew. Some of these problems, they come together like a mix in a neurological patient. It becomes little complex and you have to break it down, do your assessment in detail and then plan the treatment strategy for that person. So these kinds of things which are very small are not something that you consciously think about, you know, you bite, you chew and then you push the food, it goes to your throat, it goes to your stomach, and this is very natural to us, so automatic to us that we don't really pay attention to this. But any of these things can get affected in a stroke, and definitely it can improve. If you pay right attention, you get the right assessment done, you do the right treatment strategies, definitely it will improve. Now, how do you exactly assess and know what exactly is wrong with the patient? So there's something called as a clinical swallow evaluation, which is basically done in the bedside of the patient. You give something orally, and we know as speech language pathologists, you are trained to pick up all these issues, and based on that you formulate a treatment strategy. But what can happen is the inside structures, you don't know 100% what is happening. So like I said, the patient may be able to swallow and it goes into the windpipe causing aspiration, but sometimes if it doesn't go into the windpipe, or if that cough reflex what I was talking about is not there anymore. So there is something called as silent aspiration. In silent aspiration, the food enters into the windpipe but the patient doesn't get a cough. This cannot be picked up by doing a bedside evaluation because you don't know that it is happening. Obviously, after 2 to 3 days or a week of time, you would see that there is some fever or chest congestion, you get an X-ray done, but sometimes it may be too late. Or what can happen is something called as pooling that happens in the pharyngeal level. It goes to near the windpipe, but it doesn't exactly enter into the windpipe. Now this can also cause a problem. Later on, after some time, it may move in, very small amount may move in, and none of these things can be picked up in a clinical swallow evaluation. So to support your clinical findings, you also do your instrumental evaluation. So now there are two things that can happen here. One is called as fiber-optic endoscopic evaluation of swallowing, or FEES, where a tube is inserted through the nose and you look at the vocal fold. You can see real time, you can see the movement of the vocal folds. You give them something to eat, they swallow, you see if there is any food left in the throat, and this is one test that is done. The second test is called as the video fluoroscopic swallow study, or the VFSS, and in this test, or in the VFSS test, what is done is the patient is taken to a radiological room, and from there something similar to that of an X-ray, but this is in a video format, so that you can see clearly how the food goes from the mouth and how it is chewed, how the movement of all the structures surrounding it is, and how the swallow happens, how it happens at the pharyngeal level, and if required in the esophageal level also we can see. So how do you see the food is basically we mix a dye or we mix barium into the food, and this is given to the patient, so and you can track it easily in the test. So based on all these assessments, the instrumental evaluation, clinical evaluation and all the information together, you take it and then you formulate a proper treatment strategy for the patient. All of these stages can get improved, but you have to make sure that you do it early. You should not delay it. The more you delay it, the more difficult it is to get the function back. So as soon as you get a stroke, as soon as you see that you have a swallowing issue, you should go to a speech language pathologist and get your assessment done and start your treatment. So if you do have any more questions related to this, you can definitely ask in the comments below and we will get back to you on that. Till then, keep watching, stay tuned and follow us for more videos like this.